Good morning, everyone. Time for grand rounds. And our speaker, Dr. Furman, is with us shortly, as in 3, 2, 1. But she'll be introduced by our wonderful division chief, Dr. Clay Smith, and who is associate professor and chief of general internal medicine.
Thank you. Good morning, everybody. It's my pleasure to introduce a colleague and good friend, Dr. Furman. She recently completed a health and aging policy fellowship in Washington, D.C., where she worked in the personal office of a senator focused on hospice and nursing home policy. She is the medical director of our Trager Institute and Optimal Aging Clinic here at the University of Louisville. She's a professor of geriatric and palliative medicine and holds the Margaret, Dorward, Smock Endowed Chair for Geriatric Medical Education at UofL. She completed a residency in internal medicine at UofL in 1999 and then a fellowship in geriatric medicine at UofL in 2000. She's an experienced and accomplished developer of interprofessional education in geriatrics and palliative medicine. She's board certified in both geriatric medicine and hospice and palliative medicine. She was awarded a geriatric academic career award to teach palliative medicine to interdisciplinary teams in 2004, and she is the past chair of the American Directors of Geriatrics Academic Programs Board for American Geriatric Society. Dr. Furman.
Thank you. Thank you. And so I should say right here, basically, is that right? Okay.
It's perfectly fine.
Okay, perfect.
Microphone's over there.
Okay, perfect. Excellent. Well, thank you, Clay, so much for inviting me. And I was saying it's exciting to do this presentation because it got me back in the swing of thinking about DC, which was a great year. And thank you all for being here. And thank you, Dr. Williams, for inviting me. So, okay, so we're going to start with the case because always that's the best way to start in medicine, kind of get our head around this whole thing. And then I'm going to discuss recent policies and regulation from DC. I'm going to describe the fellowship, and then I'm going to talk about my personal policy ideas about hospice and palliative care in nursing homes. Okay, so this case is why I started this fellowship. I've been, I have medical students, residents, fellows, and I've been complaining about the same thing like my whole career. Once I figured out the problem and I figured out the solution, I was like, we really need to fix this. We really need to fix this. We really need to fix this. And I was like, I should just fix it. Instead of saying we should fix it, right? So this is the case. And in this case, it worked well because this case happened to me this happened to me right before I left to go to DC. So probably like in 2019, I was medical director of a nursing home here in Louisville, and it went beautifully because I was 24 years into my career and I knew how to work the system. I hate to say it, like you have to know the rules to play the game, right? And now 24 years later, I know. But when I first started in medicine, I was at the VA and it was a disaster, right? Because I didn't know what I was doing. So this case went well. So this is a 98-year-old male. He's a World War II veteran, and he fought in Normandy, actually lost an eye in Normandy. He's from Portland, the western part of Louisville, and never left Portland until he went to World War II. So he was a neat guy. I, talked to him at the nursing home. We took good care of him. He was walking with the walker to bingo every day, would love having the medical students and residents that came because he'd always tell his story, But he had severe abdominal pain in the ER, in the nursing home. So we had to send him to the emergency room. And then during that hospital stay, he was diagnosed with bladder cancer. And the patient and the daughter was very supportive, decided they really want to take a palliative care approach to this cancer, right? But the hospital, so that's why the hospital consulted hospice. So, in the hospital, they consulted hospice. He was supposed to go back to the nursing home with hospice. When he got to the nursing home, they're like, listen, we want to walk. He was playing bingo. He was up walking with his walker. He could not walk after this prolonged hospital stay. So they wanted rehab. So patient uses skilled Medicare benefit for rehab, but he couldn't get hospice. So Medicare pays for hospice, Medicare pays for rehab. They don't pay for both at the same time. But he really needed both, right? So what happened was we went ahead and did rehab because that's what he wanted and physical therapy and got him up walking. And after his rehab was over, we consulted hospice. But it took me like being a bird dog, like I was on it every day. Whenever I was there, I was not at the nursing home every day, but once a week I would go to the nursing home and I'd always go down and talk to the physical therapist. And I would talk to him like, is he walking? Is he walking? Is he walking? He was back to his baseline. So as soon as he was back to his baseline, I consulted hospice. But you have to have a medical director or a nurse practitioner or somebody at the nursing home like on that every day to know when the right time is, because if not, they would have kept doing physical therapy as long as they could keep skilling him, because you get more money from Medicare for that. And then he would have gotten worse from his cancer, and they would have freaked out and called 911. He'd gone back to the ER in this whole vicious cycle, which, you know, our residents see every day when these patients show up from the nursing home to the emergency room. It's like, well, what are we going to do? I mean, they're dying basically, right? So this worked out well because I knew the rules. I knew exactly, you know, when to switch from Medicare skilled to Medicare for hospice. So when I actually left to go back to go to Washington, D.C., he was playing bingo, walking to bingo every day, and he was enrolled in hospice. And I talked to one of the nurse practitioners that kept up with him, and I don't know if he's alive or not. I don't know. He was doing well when I left. The key part of this too is the patient's room and board was paid by Medicaid. So he had Medicaid and Medicare. So your insurance and who's paying for all this really makes a difference. So I want to talk about, now I'm going to switch and just kind of talk about a little bit of this policy that's coming, that's just kind of happening right now or just happened in legislation that just happened. So have you all heard about the Inflation Reduction Act? It was just on the news this morning, and when I was listening to the news on the way in, this was signed into law in August of 2022. And so I started my fellowship like in October 22. So this was big news when I first started my fellowship. And it didn't make any sense to me. I'm like, how does it have to do with healthcare? It's called the Inflation Reduction Act, you know, but it's amazing the way that these bills are titled and what they actually do. And they're very complex. And I think they just try to come up with some catchy name, right? But it does promote clean energy. That was on the news today. You know, you get rebates for like an electrical vehicle. You get tax credits for renewable energy, like solar panels. I had a patient talking to me about they're going to install solar panels on their house and get some kind of tax rebate. I'm like, great. And invest in domestic energy production. But the thing that affects us is that lowers these drug prices. So I'm going to go over specifically how this Inflation Reduction Act helps healthcare providers. So and helps patients. It caps insulin copays per month for patients with Medicare at $35 a month. And so, but I thought this is a great kind of, it's just for Medicare patients, right? I mean, that's what Congress really has a lot of control over is Medicare, which is great. And also, this is a big thing. The Secretary of the Health and Human Services can negotiate on drug prices for these really high, expensive drugs. And this was, you saw, it was passed in 2022. But this is not going to come into effect until 2026. They had a really long ramp up because everybody was basically freaking out about this because they go to the most expensive medications and they're going to start negotiating drug price. The VA already does this. The VA negotiates drug prices. And I was like, how could we never do this with Medicare patients? But now we can. So there's about 7 inhalers, 8 anti-diabetic medicines, 5 kinase inhibitors, and 3 oral anticoagulation drugs that are on this list. They had to hire a lot of people to figure this out. This is a whole big thing. And of course, a lot of the drug companies are pushing back and they don't want this to happen. But Januvia is one of the medicines, Jardius, they announced these and I mean, maybe it'll change by 2026. There's a lot of pushback. There's a lot of fighting about this. Eliquis, Xarelto, Farxiga, Entresto, Enbrel, Stelara, Novolog FlexPen, and Novolog PenFill. So we'll see. This is coming. Also, the Inflation Reduction Act capped out-of-pocket prescription drug costs for patients with Medicare Part D at $2,000 a year, which is huge. So there'll be a cap to they're really focused on these prescription drugs. Like, you know, these drugs are way too expensive. Extend the financial subsidies for the Affordable Care Act marketplace and ensure approved vaccines are covered under Medicare Part D, that they're free. Which I've had patients come to the office and they're having I can't figure out these vaccines. Like sometimes they're having to pay, sometimes they're not. So they're making it officially that, you know, these vaccines will be free. So that's the Inflation Reduction Act. Now, another big thing in geriatrics is the Older Americans Act. In 1965, Congress created this because they wanted to meet the social needs of older adults and to improve the lives of older Americans and help them age in place. And there were all kinds of regulations that, you know, went with this, and it was last updated in 1988. So the Older Americans Act, kind of the department that runs this is the Department of Health and Human Services, HHS. And under that, there's this Administration for Community Living, ACL. I'd never heard of ACL. Have you all heard of ACL? I didn't know about ACL, but one of our fellows, my co-fellow, was placed in ACL, and they do amazing things. The big thing they run is these Older Americans Act. So it administers all these programs that fall under the Older Americans Act. So like Meals on Wheels, like I was talking to Getz earlier, like all the stuff that our patients get, I just think it just magic or something. I mean, there's actually law behind this, like these Meals on Wheels. I thought maybe it was just like volunteers and donations and people getting their meals delivered to their homes. It's like, no, the federal government is actually paying for this, you know, and paying for the drivers to get the meals there. They support family caregivers. There's a lot of preventive health services. All this falls under the Older Americans Act. There's personal home care. These Medicaid waivers that we get for people to get their homemaker home health aid in the home. That's part of the Older Americans Act. Transportation, legal assistance, elder abuse prevention. There's a ton of things. And I like, how do you access all this and how do you know about all this? There's these area agencies on aging, the AAAs, and each across the whole country, everybody has a AAA. And in Louisville, it's called KIPTA, the Kentucky Endowed Planning and Development Agency. But so I always tell the residents, wherever you're going to work, just look it up. There's always a AAA somewhere, an area agency on aging that can get you all these services. And we used to have a social worker in our office way back, and I thought she was just like magic. She could do all this stuff. Well, she basically just called KIPTA, the Kentucky Endowed Planning and Development, and they got all this stuff. And I was like, oh, I didn't know that. So anyway, it's amazing when you start digging like where this stuff comes from. So you can see that this Older Americans Act has a lot of money. It's like billions of dollars, like 1.91 billion in fiscal year 12. And you can see under COVID, they put a lot of money into the Older Americans Act to help older adults, because during COVID, the people that were dying were older adults, right? And so they put a lot more money into all these programs to keep people healthy and keep people at home. Okay, so what happened was in February 2024, which is like what, a month ago, ACL released a final rule to update the regulations for implementing these new programs. I mean, implementing programs with these new rules. So come to find out, there's three branches of the government, right? The legislative branch, the House and the Senate, makes these laws, but who like implements them and gets them to work is the executive branch, you know, the president. But under the president, there's all these agencies, and one agency is the Health and Human Services, right? They make the rules. It's all this rule making. So they released a final rule. They do these proposed rules and they become final rules. And so these new regulations take effect like a week ago, but entities have until October 25 to actually comply. So they give people a ramp up because they know a lot of the stuff is going to be hard to do. So the new stuff in here was guidance for the National Family Caregiver Support Program. So there's a big push to try to get caregivers paid and also just have more caregiver support. Native American Caregiver Support Program. These were all authorized in the last update. So it's interesting because I always thought Medicare and the whole way the whole system was set up was for like hospitalizations, acute care, the rehab that goes with it. But now what I saw on Capitol Hill last year, the big push is to kind of have people age in place to support the caregivers, not just for the acute illness, but to prevent illness and to have like the long-term supports and services and have like aging in place be more upfront and paid for. There's also these national strategies. That's what I talk about, to support family caregivers. There's a whole bunch about that. There's a national strategy on hunger, nutrition, and health. So like the executive branch, Health and Human Services, the White House will release these reports and release these guidance. So other things that's going on, there's a lot of medical social care integration, trying to kind of be upstream, not wait to the, like, I think, Dr. Williams, you talk about this a lot, like, don't fix it after the fact, like prevent it, like the whole turning off the water, cleaning up the spill. They're trying to go upstream and like prevent the spill to begin with, right? And so that's a big area. Another one is big nursing home regulations is a big area because COVID, I think, really did highlight like these nursing homes had issues, and that's where a lot of people were dying during COVID, was the nursing homes. And they started doing all this investigation and realized not every nursing home is like up to snuff. Some are great and then some are not, you know, and so how can you make them all great, right? And so a lot of it's staffing ratios. So I'll tell you a little bit later about what I did, but I worked on a letter about these staffing ratios, and this transparency and ownership is a huge thing. There's a lot of private equity in nursing homes. And like I've been a medical director of nursing homes for 20 years, my whole career. looking back, like who actually owned my nursing home? I'm not exactly sure. Like I knew who ran it, but then who's putting the money in it is not always the same thing. And it's really hard to figure it out. So they did finalize the rule with transparency and ownership. And so that's huge because they shut down one nursing home and you're like, oh, that's a bad nursing home. Well, come to find out this nursing home over here, it's the same owners, but you would not know it just looking at a piece of paper. You have to almost file a lawsuit because the lawyers can do discovery and actually figure out who owns what. But why should we have to go to a lawsuit? Why do we have to have the attorneys do the dirty work? Why can't we just have it on the website like Care Compare? So they're starting to put that got finalized. And the letter that I wrote about this, they've been trying to do that 10 years before, and they put out a proposed rule. We're going to have all this transparency. There was such pushback that they had to just kind of cancel it. And so it was amazing that it got through this year. And during the State of the Union, I don't know which one, I guess right before it was like in the August or so of 2022, right before I did the fellowship, Biden's State of the Union mentioned nursing homes. That was the first time nursing homes had ever been mentioned in the State of the Union. So if they're starting to get attention to it. And then address recurring low performing facilities. So they're, really trying to work on that. And this Medicare Advantage was a huge thing. And I didn't understand Medicare Advantage as much, but there's not as much penetration in Medicare Advantage. And I had patients that had Medicare Advantage, but like in Louisville, it's called Humana Gold Plus or Humana Advantage, or, and there's traditional Medicare, like plain old Medicare that we always know that you have to have the 3 midnights to get a nursing home stay. That's traditional Medicare. Well, Medicare Advantage, it sounds great. And Medicare Advantage was started as part of the Affordable Care Act because they want to have more competition and Medicare is going broke. We're going to save Medicare. And this was a solution. It's all these like individual plans. But what happens is you see all the commercials, like all the TV commercials, all these Medicare Advantage, you get like free dental, free vision, you get free groceries, you get all this free transportation, all this great stuff. But with Medicare Advantage, you have to have a prior authorization for everything. And guess what? Anytime you got to get a prior authorization, it's denied. Like your nursing home stay is denied. Medicare, traditional Medicare, you just need 3 midnights. So it sounds good. And if it sounds good, too good to be true, it probably has a hook to it. And the hook to it is when you actually need medical care, it's denied. So yeah, you get your vision and hearing and all this great stuff, but when you actually need like big, expensive items, it's denied. And so what's happening is a lot of healthy people are in Medicare Advantage programs. And then these Medicare Advantage programs is like, when you really need to be sick, it's like, well, maybe we can't meet your need. You probably should just go back to traditional Medicare. So what's happened is traditional Medicare is still going broke and Medicare Advantage programs are making all the money because it's like Humana is making all the money or whoever is the, whatever. So there's a lot of stuff going on with this. And there was a big debate among the fellowships and the fellows. We had a lot of speakers and we had like a panel and they're fighting back and forth, about is it good or is it bad? There's good parts and there's bad parts, right? But what's happening with Medicare Advantage, there's a lot of marketing, like kind of scam marketing. I mean, you see these TVs, they're calling people up and whoever answers the phone. So what happens is like, sometimes people with dementia answer the phone. Sometimes people with disabilities answer the phone and they say, oh, we have all this great stuff. And they're like, oh yeah, sign me up. So they're getting off their traditional Medicare under this, and then their family comes back and like, no, we don't want that. But they've already signed up and it's a lot to undo it. So it's a big mess and they've done all kinds of hearings in Congress about this. The risk adjustment, this is like the cherry picking. The healthy patients, the low risk patients are on Medicare Advantage. The high risk sick patients are on traditional Medicare. And then the supplemental benefits of what they'll supplement, like the food, the transportation. One of the fellows that was from Florida said these Medicare Advantage programs, like, oh, come get your nails done and you can get and so is that a supplemental benefit? So it's all very messy, but that's a big area to watch because something, I don't know what's going to happen. Another big exciting thing that's happening is the White House Conference on Aging is happening, and this happened 10 years ago. And so the next one's going to be in 2025. So everybody's like trying to get prepared for this because our country is aging, people are aging, and we have to have a plan and not just like say good luck. So that's what this is all about. Okay, so that's the big policy and regulation things that are happening. I want to talk about my fellowship just a little bit. And you can see here who sponsored it: the John A. Hartford Foundation, West Health, the Atlantic Philanthropies. those are the big sponsors, but also the VA is a big sponsor. A lot of about a third of our fellows were from the VA system. So the VA will like let people off and give them time to do this. So I worked with Senator Elizabeth Warren. She's the U.S. Senator from Massachusetts. And the way it works is you just once you get accepted to the fellowship, you do an orientation in October, and then in October, November, you start interviewing at all these offices. You can work on the legislative branch, you can work in the executive branch. You can't work for the judicial branch. They do have Supreme Court fellows, but that wasn't part of our thing. So, so at first when I came in, I really thought I was going to work for CMS, because CMS is Medicare. This whole issue, this patient that I was talking about, it's a Medicare issue. But CMS, and I interviewed for CMS, they're actually working remotely at the time. And I was a residential fellow. So I actually moved to Washington, D.C. My husband and I went and got an apartment in downtown. And they're like, you didn't move to Washington, D.C. to be in your apartment on Zoom all day. You know, they said you should work on Capitol Hill, because Capitol Hill was pretty much in person. A lot of the agencies were still virtual. I did my fellowship from October 2022 to pretty much October 2023. So I just interviewed for all these places, and I interviewed the Senate, the House, and I also interviewed for committees, like the Senate Special Committee on Aging or the Senate Finance Committee. So so when I just interviewed for all these offices, Senator Warren's office was the only one that, when I started talking about the nursing home and hospice, which I'm all excited about, their office was engaged and could have a conversation. Other offices just kind of glazed up. They didn't even know what I was talking about. And I now, looking back, I understand why, because it's what her committee assignments were. And I didn't understand this before, because I met with Mitch McConnell's office, I met with Morgan McGarry's office, I met with all of our, Kentucky delegation. And some people were like, they didn't know what I was talking about. But it's because the office really knows, and the Senate really knows, based on what the committees they're on. That's where they kind of do their in-depth work. So the Senate Special Committee on Aging, I mean, of course, they know about nursing homes. They're aging. The Senate Finance Committee is over Medicare, and so they know about Medicare. The Senate Armed Services Committee and the Senate Banking, Housing, and Urban Affairs Committee. And so even with banking, that's a lot about, I did a whole report on medical debt, and that's the finance and the medical debt, it all is intertwined. And even the Senate Armed Services Committee, I did work on how to make sure the military is healthy, right? So they knew it was a great office to work with, because they understood what I was working on and understood what they were working on. So there's me and Senator Warren, and the whole time I was there, I never got a haircut. So you can see my haircut. I was like, I couldn't figure out where to get my haircut. So this was my role, was to serve on the health team and the oversight team. And so I worked with fellows. Her office actually had 5 fellows. They had a legal fellow. They had me, a health and aging policy fellow. They had a AAAS fellow, which is American Academy of Academic or Advancement of Science fellow. They had a Teach for America fellow, a tech fellow. I don't know. And come to find out, there's Robert Wood Johnson Foundation fellows. Some of those fellows, Capitol Hill's full of fellows, because what happens is those fellows are embedded in the offices, and they can kind of advance the principles that those organizations want, which is very interesting. So this is the aquarium in Baltimore. This is Tess Beyer. She was my supervisor as the health policy advisor. So you can see there's a lot of young staffers. I was older than a lot of the people, but also like this Brian Cohen was my oversight and investigations. He's director of oversight and investigations, and he was my supervisor, and he was my age, and he's worked on Capitol Hill his whole life. But Senator Warren's office is the only office, one of the few offices that have like an oversight team. But what happens is the Senate and the House are supposed to do oversight. The legislative branch is supposed to do oversight for the executive branch. There's a lot of checks and balances, and that was designed on purpose by the Constitution. And that's why Getz and I were talking, it's like, are you like disillusioned after this? Actually, I just understand it a lot better now. It never really made sense, but after going through orientation, they had all these PhDs that would write papers on books and all kinds of, government and policy and all this politics. And one person gave this presentation, and he was like talking about how the Constitution, how it was all designed. He's like, our government works exactly the way it was designed to work. Because, when it started in 1700s from England, no one wanted a king, right? And so there was all these checks and balances. So like nobody would have too much power, right? And so all these checks and balances, make sure that really it's status quo, like nothing's going to really change unless it's a really important thing. So that's why like people get so frustrated. It's everything's so slow. Well, it's slow on purpose. We don't want things to change really quickly because we want to make sure everybody's in agreement and it's the right thing to do. So everybody's like, oh my gosh, government's so crazy, it doesn't work. It's like, it works exactly the way it was designed to work. If you, so these were our fellows on they all got to lunch the last day. So that was fun. And that's at Union Station. That's the other thing about DC is like every building is beautiful. You go to Europe, you go to these other countries and you're like, oh my gosh, they have such beautiful buildings. Where they're all in Washington, DC. So go check out all these beautiful buildings. So my role was to meet with all the constituents that came through Senator Warren's office that were interested in health and that were health care professionals, like the doctors, the nurses, the pharmacists, because they all wanted to come meet with the senator. And I don't know, you think you're going to meet with the senator, you're not going to meet with the senator, you're going to meet with me or a staffer. But they were so happy to meet with a doctor because usually they're meeting with people that maybe don't really understand the ins and outs. So I wrote a lot of oversight letters and reports and memos. And I mean, I'm used to being a physician, you're up and seeing patients and you're running around. I was like in front of a computer writing and typing and doing research all day. So it was like, oh my God. And so when someone wanted to come meet with me, I'm like, yeah, I'll go meet with them because I'm not used to just sitting in front of a desk all day in front of a computer writing and doing research. But it was great because it gave you time to research and think. And but it took me a while to get the pace was different. Senator Warren's office was really big on fact checking. And no memo or oversight letter report or anything went out without fact checking. So I had to read letters from like the Department of Defense letters and education letters I knew nothing about, but it was really fascinating to read everybody. And I'm an English literature major, so I love doing the fact checking and correcting the grammar and stuff. We had weekly oversight meetings, health meetings, legislative meetings. So I was in all those meetings. I got to meet with CMS, which was really cool. And it's amazing. So you have a Senate.gov email. So when you get an email from Senate, people actually responded to your email right away. And they're like, oh yes, So I met with the U.S. Preventive Service Task Force, really about a lot of COVID vaccines and COVID things. A lot of advocacy groups, researchers about policy issues our office was trying to advance. I helped staff Senator Warren. So that means that you have to write the questions, prepare the witnesses for these hearings. So it was a Senate Special Committee on Aging had a hearing on nursing home safety survey process. So you think these hearings are just like, oh, you just show up for the hearing. No, they're very scripted and it should be prepared. But then you see these hearings that go off track, like the president of Harvard and all this stuff. I'm like, does somebody not prepare these people for the hearing? So we prepared our witnesses. I don't know. I guess each office does it a little different way, but the hearings are organized by the committees. So the committees really are the ones that invite the witnesses and things. But each senator gets to ask the people that are testifying questions. And so that's what our job was, to kind of get these questions together. But the hearings are really a way for the senators to pontificate a lot of time and just kind of get their ideas across. And they ask these very pointed questions to get their ideas across. I review the questions for the banking hearing on oversight of credit reporting agencies. So this medical debt. So there's these scam credit cards, like these predatory credit cards, these medical, and in geriatrics, most of our patients have Medicare, so they all have insurance. But a lot of patients have these medical credit cards, and they're putting like so much money, they're getting so much in debt on these credit cards. When actually, when you start looking at these health systems, some health systems a little bit more sketchy than other health systems, they turn over the medical debt, the hospital debt, to a credit card, whatever you're trying to like get their, the debt collector. Thank you. And these patients would qualify for Medicaid, but they're like, oh no, they'd rather get the debt collectors after them. So there's a lot of sketchy stuff going on, but that's the role of the senator to have oversight, right? And I got to develop this policy legislative proposal that I'll tell you about at the very end. Okay, so I got to meet with constituents. This is like the largest constituent group. And this is the Alzheimer's Association. And if you can see, they all wore purple. And I just happened to wear purple that day. So it was like a perfect picture. So that was a great, and this is the Hart Building. So Senator Warren's office is in the Hart Building, and that's really close to the Supreme Court. So it was cool. It was a nice building. Okay, so the report I did was medical debt. I'm not going to go into the details. This one report was I will just say about medical debt. Where do you think most people in the country, what region of the country has the most medical debt? And we have an idea. If you look at a map of the United States and you look at the colors, where does the medical debt occur in the United States of America? Just
Southeast.
South. And these are the states that don't have, they did not sign up for the Affordable Care Act and Medicaid. They don't have, like, so Kentucky under Governor Beshear, Andy Beshear's dad, agreed to be part of the Affordable Care Act and have expanded Medicaid. So these about 10 states that don't have it, it's like Texas, and they're still like these southern states. North Carolina is the last state that, the most recent state that did kind of go into this the Affordable Care Act. So that was fascinating. I never really looked at it before. I did a report on quality measures in nursing homes owned by for-profit real estate investment trust. Have you all heard of REITs? Anybody heard of REITs? I've never heard of REITs. REITs are similar to private equity. It's all these like private money, people trying to, the shareholders, the investors making money off of Medicare, Medicaid is giving money to take care of these patients, but actually it's been siphoned off and given to the shareholders. It's scary. I did not even know this was happening. So, and guess what? The quality measures and people that lived in nursing homes that were owned by REITs or private equity were lower, less quality. Imagine, I couldn't imagine that, because they're paying their like these shell companies, which happen to be like their daughter's company, that actually they're paying their daughter to like get this money. So it's a lot of stuff. I did a lot of oversight letters. This is when I called Getz. I was like calling my friends and I was like, Getz, tell me about Keytruda. Like, I don't understand all the details. I had to write a letter to the U.S. Patent and Trade Office, basically saying, don't approve another Keytruda patent. Because when they hit these medicines have patents, it used to be there was no patents. But then Congress said, hey, we need to have patents so people can, like, actually invent new things. But the patent usually lasts about 20 years. So that way you can get back your money for all your research and development costs. Well, what they keep doing is extending the patent, which makes the medicine more expensive. If it was generic, it'd be cheaper. We're trying to have cheaper medicines for everybody. But they would, the latest thing, I don't even know what happened. Do you know, I don't know, did the patent get extended? I have to look that up. But they wanted to extend the patent because they were going to go from, it's an IV infusion, right? Versus sub-Q injection. And that was a big new, get a patent has to be innovative and novel and new. I was like, sub-Q injections have been around 100 years since insulin or whatever, I don't know what ended up happening, but what happens is these drugs companies, big pharma, they tell the FDA, oh, it's safe, it's been around, it's good, it's fine, it's not novel. And they tell the they tell the patent office, which is under the U.S. Patent and Trade Office, oh, it's novel, it's new, we need to get a patent on it. So they're saying there's two federal agencies, and they're saying the opposite to these two agencies. So the big thing was to get the FDA and U.S. Patent and Trade Office to actually talk to each other and see, like, what's the real story. So anyway, that was one. The U.S. Preventive Service Task Force, it was all about COVID-19 testing as a screening tool, because if it's a screening tool, then it's paid for by insurance. That was the whole thing. Letter to CMS about finalizing this proposed rule for nursing home transparency, and it was finalized. I feel like that was like one success. And then a letter to CMS about reversing the prior administration's deregulation of nursing home, because the nursing homes were deregulated a lot, and then COVID happened, and then it's like, oh, maybe we should regulate them. And it's like, yes, go back to the regulations you had before. It's a balance for sure. A lot of memos, come to find out that's how everything's done. It's like everybody writes a memo, everybody writes a letter. So you all can write letters to CMS, you all can write letters, a lot of groups get together, doctors that write a letter with like 10 people signing it. But Senator Markey is the other senator from Massachusetts. So that was a co-signed letter about America's health insurance plans, about continued Medicare coverage for at-home COVID tests, about nursing home staffing requirements. This letter, Senator Casey and Wyden, this was a huge long letter trying to get everybody to agree to everything that was in the letter. And then to support the appropriations request. So for long-term support and services. So these appropriations are also like earmarks, and each constituent can say, hey, I want money for this, I want money for this. So they were really, so Senator Warren really did want to have more long-term, more money. Appropriations is money, right? More money for long-term support and services, LTSS. All right, so this is a hearing, and it's funny if you can see what you see on TV and what happens in real life is not always the same thing. So this is a hearing, and hardly any senators are at the hearing. And I was like, what is the deal? Because you look at TV and you just see like with the cameras focused on this one person, but they're all running back and forth to other committee meetings and they have to vote. I'm like, well, why don't you all get your calendars organized so you can all be there at the same time? I mean, I don't know. But in the back is a staffer. So I was actually sitting in the back there one time. It was pretty cool. But some of these hearings were packed. My husband was there, he's an attorney. So he was all excited about going to all these hearings. And he went to one about like the UFOs. It's not called UFOs anymore, but there's a hearing about these unidentified, what are they called? I forgot, objects in the air thing. It was a line a mile long down, and like he couldn't even get into the hearing, but you can watch all these hearings online. And they're all archived. So like you can go to the website for the Senate Special Committee on Aging, or you can go to the website for the Senate Finance Committee. And there was hearings about all these, like the Medicare, the Medicaid, all this it's all the UFO hearing. You can go look at it. So, okay. So I just want to talk about what I learned. And I learned a lot. But my proposal that I really wanted to work on was this hospice nursing home stuff. And everybody I interviewed with, everybody I talked to, I kept talking about it. And finally, about halfway through the fellowship, my supervisor was like, okay, Christian, you can start working on your proposal now. You've talked about it enough. And so I started off with, like, because I've been talking about this nursing home issue, this Medicare issue with rehab and hospice. I knew the issues, and I was like, well, we can't do this because the law says this, and we can't do this because this is going to cost too much, because, and Tess was like, listen, Christian, the US government has plenty of money. She said, don't worry about the money. I was like, wow, don't worry about the money? I was like, we always worry about the money. She's like, it's just where you put the money. It's just a matter of priorities. We can shift money around, we can find money, da, da, da. And then I was like, well, the regulations say this and the rules say this. And she's like, Christian, we can rewrite the laws. We can change the regulations. I'm like, it just blew my mind that we could actually do like anything we wanted to do. It was really cool. So, because the policy, when you write the policy, you want to have she's like, you figure out the best thing for the patient, and that's what we should do. Great. And so you start with the best thing for the patient. And then by the time it goes through House and the Senate and committees, it's already going to be parsed down to like something totally different. But don't start with like the worst, start with the best, and then you can figure it out. So anyway, her office believed like anything was possible. Like, it just really opened my eyes. There's enough money. It's all about priorities, and we were putting the money. But I really thought we needed a law, like, to switch all this around. And they were like, oh my God, getting the law passed through the House and the Senate, getting the president to sign it, it's hard, because the way our government was designed was for nothing to change. So the easiest way to get things to change is through policy and rulemaking. I was like, what are you talking about? So I'll tell you about it a little bit. But those letters that we were writing, like, now there's a rule about transparency in the nursing home. That was not law that was passed by the House and Senate and da-da-da. It was CMS made this policy. So advocacy makes a difference. I meant to say, when the whole Alzheimer's Association was there, their big thing that they're advocating for was Leqembi. Have you all heard this? This is the new monoclonal antibody for Alzheimer's dementia. It's an IV infusion, and the FDA did not approve it. Well, finally, the FDA approved it, and then CMS wasn't going to pay for it. Then finally, CMS paid for it. The VA paid for it before CMS did. They were saying, when they were coming to advocate with me, this was like in January, February, like a year ago. They were saying, hey, listen, the VA is paying for this. Why isn't CMS paying for this? So the advocacy did make a difference. So, you write these letters, you go visit your Congress people, it makes a difference. Congressional offices, like, I was doing all this writing and reading and research, where you're reading these research papers that we're writing, right? And so press articles, op-eds, if, having a doctor say something really does carry a lot of weight with Congress. So if doctors could be like, this is what we should do, and write a letter about it, write an article about it, they read it, they cite it, they put it in their letter, they quote you, because they don't know, they don't, these staffers, they don't really know the issues. They really need us to say, this is what should happen. We need more healthcare professionals' input. So you all should do this fellowship. And also what I learned is I really need family, friends. I needed UofL support. I would not have been able to do this as a full-time in-person fellowship without all that. So I'm just going to show my people that helped me through. This is my kiddos and my husband. We got to go to the Kennedy Center. That was really cool. My parents came down, and this was in the Capitol Rotunda. This, my brother and sister-in-law came. We got to see the cherry blossoms. The cherry blossoms are blooming now. And so kind of, I missed that. They all came for spring break. These are the fellows that I worked with in front of the Capitol. They're from all across the country. And these are the, this was the AGSF fellows, the American Political Science Association. Some of these guys, like the guy at the top right, he was a CIA fellow. So some of these, the CIA sends fellows because they want to know how to work better with the Congress and the administration. And this is in the Senate dining room. So like we would see like Senator Warren in the corner sometimes and all the senators, and it was kind of cool, but we couldn't take a picture of any of them, you know, but it was cool to be in the Senate dining room. And this is my kiddos and my mother-in-law. It was great that my family got to come visit. This was so cool. Okay, we have a gold standard award for optimal aging luncheon every year in geriatrics and the Trager Institute Optimal Aging Clinic, where we honor people over the age of 85. So I went to Ben's Chili Bowl. Dean and I, my husband and I went to Ben's Chili Bowl just because we were going, we had a list. Dean made a list of every place we should go in DC. This is like a famous place. And this is Virginia Ali and her husband started this. And this is in the area that was called Black Broadway in the 60s and 50s. And this is where all the doctors and the dentists and everybody, and their Chili Bowl restaurant was right there beside it. And so I was just talking, I just was all along the wall. There's tons of pictures and I was just reading all about it. And this woman came up and she said, that's me. And so she was just talking, and I told her I was a geriatrician. Well, she wanted to tell me the whole story. She turned 90, wrote a book. So we gave her the Gold Standard Award for Optimal Aging, and I got to present it to her. And she wasn't able to travel to Louisville for the award, so I just gave it to her while I was there. So that was really cool. So if you want to nominate people for the Gold Standard Award, the deadline is May 1st. Anybody over the age of 85, it could be couples across the world. If you have family and friends in other parts of the world, we'll send them the certificate. We'll give them their medal by mail. It's a great event. They get a corsage and the president of the university comes, the mayor comes. It's in September. The luncheon's in September. Okay, so to summarize the fellowship, the deadline applies in April, so you have a month. I would recommend get yourself together and apply next April, because you have to have letters of recommendation and all this, but anybody can apply. Physicians, nurses, PhDs, social workers, nurse practitioners, chaplains, pharmacists, residents. One of my fellows was a fourth-year psych resident. I'm like, how does your program director let you do this fellowship? But it was a part-time. I was a full-time fellow. Everybody else was a part-time fellow. And the part-time is like 20% of your time. So you can do it any which way you want, like a month, 2 months in a row, or just a week at a time, or a day at a time. The fellowship buys out your clinical time. So it's a paid fellowship, and you can be full-time or part-time, and that's their website. So I'd highly recommend it, because some people that were part-time, it was basically just virtual. They just zoomed in to their fellowship, you know, and then you would come like, you know, for orientation to DC in October and things, and you'd come periodically. Okay, that's that. And now I'm going to talk about policy ideas. This is my policy idea to improve end-of-life care in the nursing home. Okay, this was my thing I've been working on for like, in my head for like 20 years, talking to everybody about it. So we talked about the case. This is our case from before, where it worked really well, right? This person got what he needed. He was able to walk to bingo and have hospice, right? Because really hospice helps people in the nursing home die well. Because if you don't have hospice in the nursing home, it depends on the doctor and the nurse in the nursing home. But a lot of nursing homes don't know about end-of-life care. And if something happens, they'll just freak out and call 911. So the way it did not happen well was, I used to be chief of hospice at the VA, like way back. And I would have patients, these are veterans that were dying, but they're probably going to live for a few more months. So they can just like live at the VA the rest of their life. So we would send them to the nursing home to die at the nursing home. And I would consult hospice, and I'd send them to the nursing home. And I thought, did a discharge summary. I thought everything was fine. Next thing I know, they're back in the ER at the VA, like dying, like short of breath, gas. I'm like, why are you here? Like, what? They never got hospice. I'm like, how did you not get hospice? I ordered hospice. I thought people follow doctors' orders. They never got hospice. Because when they got to the nursing home said, you want hospice, pay us $100 a day room and board, or you can stay here free and use your skilled Medicare benefit. So what do you think people chose? Free or $100 a day? They chose free. They would skill people, and they would, and at the time, the only thing the nursing home knew to do to skill people was physical therapy and occupational therapy. So making these dying veterans like walk up and down the hall, I'm like, just let them lay in bed. So I couldn't figure out what was going on. And so when I figured it out, it was a payment issue with Medicare. Medicare will allow you to choose hospice, or Medicare will allow you to choose skill, but you can't choose both at the same time. And so we did a workaround. And the workaround is what we figured this out, like at our nursing homes, that we would just skill people for end-of-life care. It was really fun because you can skill people for physical therapy, occupational therapy, speech therapy, complicated nursing care. Like if you're having PEG or trach or those IV antibiotics where you send people to nursing home, that's complicated nursing care. Well, end-of-life care is complicated nursing care because you're changing orders and doing stuff. So we would just skill people for end-of-life care. And I would always send people to the nursing homes I knew that knew how to do palliative care. Like Jane Cornett is one of the doctors, and Stacy Mandrola. I would send them to their nursing homes or my nursing home or Dr. Laura Morton's nursing home because I knew that they could do it. They would not just call 911 and send them back, and we'd do good palliative care. And then when the rehab was over, they would get hospice, right? But some people don't know how to do it. Some nursing homes they're afraid, everybody's afraid they're going to go to jail or Medicare fraud. Like you can't skill people and you can't do this, do that. Because I'm not, and like in this case, my patient needed, this 98-year-old World War II veteran needed both. He really needed rehab and end-of-life care at the same time. And it happens both ways, where sometimes they're admitted to nursing home for rehab when they need end-of-life care, but my 98-year-old was admitted for rehab. You know, it can go, you just need to do what the patient needs, not what like Medicare pays for, right? Okay, so this is a good article, Rehab to Death by Lynn Flint. And I'd read her article a million times and quoted a million times. But finally, because of Senator Warren's office, I just like emailed her. Of course, she emailed me right back and we Zoomed. And last week was the American Academy of Hospice and Palliative Medicine's national meeting. I got to see her in person, and she does look a little different in person than by Zoom. And so it's so cool. Like these are real people writing these real articles that we're quoting every day. And then John Oliver's YouTube video, I don't know if anybody watches John Oliver. He was so funny. But it's basically how we're torturing these dying patients, making them walk up and down the hall, and how it's a little bit of a scam that these nursing homes and then physical therapy are billing when they're just trying to get the money, right? And I get it because these nursing homes don't have enough money. And it's so, some of them, well, they say they don't have enough money, but actually the money sometimes is going to their stockholders, you know? So it's fascinating. So I'm going to go back to this case just to show you that this worked well, but it took me 20 years of figuring it out. And we don't want everybody, we should be able to have this as a policy, as regulation, so people just know how to do it without having to like figure it out, right? And they have to have policy and regulation so the nursing homes don't feel like they're going to get a fine. There's so much regulation around the nursing home, they feel like they're going to get in trouble if they don't check all the boxes exactly the right way. So we need to revise the skilled Medicare benefit. Just say it. Don't say, oh, you can skill people for nursing care. You can skill people for PT. Say you can skill people for end-of-life care and just be honest about it. And so the same rules would apply. Like right now, the rules are when you're skilling people for rehab, the first 20 days are fully paid by Medicare. And then day 21 to 100, Medicare pays 80% and the patient pays 20%. And the maximum rehab is 100 days. So the question is, what if they don't die in 100 days? It's like, well, I don't know, we have to figure this out, right? It's not a perfect solution. But if you're a nursing home, you say, okay, I'm going to skill you for end-of-life care, then you have to do a good job with it. So we have to have some checks and balances to say, because what's happening now, this is happening now. A lot of nursing homes will say, no, we don't want hospice. We're going to do palliative care. We're going to do it. We're going to do it. But they don't. So they have to then provide the same, they either should be able to consult hospice, or if they can't consult hospice, then provide the services that hospice would provide, like a doctor, nurse, chaplain, social worker. A lot of nursing homes do not have chaplains and social workers. And if they have a social worker, they don't know about end-of-life care. You have to be able to have bereavement. Hospice provides bereavement for 13 months. Does the nursing home going to call these families and provide counseling for these families? Some of them need it, some of them don't, but they have to be able to offer it. And what if the nursing home can't control their pain and symptoms? If they have hospice, they can go to the hospice unit. Are they going to have a unit where these patients can go to actually get the care they need? So we have to have some rules and regulations around it. And people are like, oh, this is going to cost too much. But there's huge cost savings. But I wasn't sure. And even my office wasn't 100% sure. The Congressional Budget Office scores all this legislation and scores all this policy stuff. And would they give it a good score or not? So I actually met with the Congressional Budget Office and say, hey, listen, do you look at cost avoidance when giving a CBO score? And they do. So that was like, I had to tell the office, listen, is cost avoidance counts. It's okay. Because how would you do any primary care and preventive medicine if cost avoidance didn't come into play? But the CBO said, you have to still get some return on investment pretty quickly. The cost avoidance can't be so far out that they can't measure it. It's like, okay. But you save money because you're not going back and forth to the emergency room. You're not having these long ICU stays. You're not having all this hospitalization, all this workup. And also the emotional existential costs of like torturing these patients and making them walk up and down the hall, doing physical therapy, occupational therapy and speech when they're dying. Okay, so the next step, when I was kind of leaving the office, that was like the last thing I did, is we did meet with CMS about this, but come to find out, I don't think we were talking. I mean, CMS is huge, right? And we met with the people that like knew Senator Warren's office. They didn't exactly know about all this nursing home hospice issue. They kind of did, but I think the next step would meet with the nursing home hospice people really more specifically at CMS. But when we were talking to them about this, changing these rules, are like, the rules, we don't have to change any rules. The rules are there. You can skill people for nursing care, which is end of life care. So just do it. Yeah, you can say just do it, but people are afraid to do it. And if they do it, they're not doing a good job of it. So there's going to be more follow-up. So really the next step would be a letter to CMS asking them to pilot this. Have you all heard of the CMS Innovation Center? It used to be called the Center for Medicare and Medicaid Innovation. So I was an innovation advisor for CMS Innovation Center like 10 years ago. That's kind of what got me started about all this a little bit. And so they're doing all kinds of pilots to see if it would work or not. So this should be piloted to discover if there's unintended consequences. What's the scam going to be? Like, everybody's trying to make a buck off this stuff. So we don't want to just roll it out to everybody until you pilot it first. So asking them to pilot it. And then I am working with Lynn Flint and some other people to publish a paper on this, because there's not a lot in the literature about this. All the doctors kind of that do nursing home work know this, but there's not good documentation. So we're going to do a policy paper on this. And then the next step is to ask the Governmental Accountability Office, the GAO, to really do good data collection on this. How many people are dying when they're on their skilled benefit in the nursing home? A lot, I think, but there's not good numbers. And it might be legislation, and the legislation would be like, okay, CMS Innovation Center, you're going to have to pilot this. That would be the legislation. But we try to do it through rulemaking because it's easier. So there's a lot more about this. I don't have time to go through it all, but I'm going to present on this at the Optimal Aging Conference, and there's lots of other good topics about older adults, and it's April 20th to 23rd at the Brown Hotel. This year's the first time it's in person since a long time, so if you want to register, please do so. And also, I'm going to be doing palliative medicine grand rounds on Tuesday, April 9th. And I'm going to go in more in depth about this nursing home and hospice, more hospice, lots of hospice. Hospice was a hot topic in DC because that right before I got there, there was a lot of scamming going on in these hospices around the country, like these fake hospices were billing Medicare, and there was like no patients being seen. So I'm going to go into more depth. And if you have questions, this is my contact information. That's my cell phone. So feel free to call. Any questions? So that's it.
Well, thank you, Dr. Furman. Very informative. I'm glad you were able to do this. And now we have an expert in the room and you can solve all our.
Yeah, that's right. At least you know who to call, right?
This is the longest question you've probably ever heard, but the theme here is the solvency or insolvency pending of CMS. And so I come at this with a long history of advocacy and from 4 different perspectives. One is, we have resisted a single payer. So in your comments, maybe you could tell us if you heard or saw any traction for single payer on Capitol Hill, because I think the most of the resistance has been with us at the American Medical Association. And it's changed from 90-10 to 80-10, and since I think it's like 55-45 right now. So we could actually be the ones to help. The second one is that whole idea of the Inflation Reduction Act was concerning because you actually could actually read a list of the ones that are being covered. Well, it needs to be a lot more than that.
Yes.
And hopefully there's a board who's engaged, who's looking, particularly the ones that are, I'm going to give you a big example, which would be having more, indigent patients with a disease, like older African-American men getting amyloid and needing to tafamidis for $276,000. Okay,
Wow.
The third issue is, where's the money going to come from if we're going to solve it? Because you're talking about optimal aging, but our life expectancy is going down. Now, how is that possible? Well, the bad news is it's drugs and early cardiovascular disease because nobody's doing that plant-based diet. And so we're squeezing the middle. Americans are aging, but they're dying in the middle. That's our tax base. Those people are supposed to be at work paying
So, yeah.
to pay for this. So the next one, of course, is, you identified a lot of profiteering. A lot of profiteering in our system. And the CBO and everyone else can actually see where the money's going. Why can't we just
Fix
stop
it.
it? Yeah, that's
Fix
right.
it.
And the last one, obviously, and I'm always gonna go there, is the lack of prevention. And that is, if we have 6 pillars of lifestyle medicine, why isn't Medicare and the bicameral approach why can't we all get together on this and say, we want to make sure that everybody has a loving environment, plant-based nutrition, this exercise program, and understand healthcare from the point of view of getting away from all the substances that we use and promote.
And that make you rich, like the candy bars and the Cokes and so, yeah.
Exactly. So
Yeah.
of those 5.
I know, right? Yeah, this is great. I mean, it's exciting time because I think people are starting to have these conversations because you're like even like you said, the American Medical Station is starting to change a little bit. This Medicare solvency, that it's funny because that's what you hear about. Everybody's like, oh my gosh, the house is on fire. We're gonna have no. I was really thinking there'd be no Medicare. When I was on Capitol Hill, they're like, Medicare is going to be here forever. There's no appetite to get rid of Medicare. And what it is, it's just a matter of moving money. It's moving money around. There's plenty of money, actually, come to find out. It's just who gets the money. And then this Inflation Reduction Act and these medications, these are the first list of medicines, but part of the legislation is this, and then in 5 years, there's more, and then 5 or 3, I don't know the exact time frame, but it's a rollout. Of course, everybody's freaking out. So they want to just start with like certain number of drugs first, and then the next cycle, there's more drugs. The next cycle, there's more drugs. So it's going to keep coming. I'm not sure exactly what drugs are on the list. I don't think anybody knows. They just announced these drugs.
There's a committee or?
There's they said they hired like 97 people to kind of roll all this out. So yeah, I would definitely use your advocacy to start telling them which ones should be the next drugs on the list, But for President Biden, it made it very clear to all the agencies like Health and Human Services, Department of Defense, everything has to be done with a lens of health equity. Like everything, every legislation, well, they're not doing legislation, but every policy and it's all with this lens of health. So these medicines, they did the most expensive, but health equity is everything has to have health equity as part of it. The life expectancy and the prevention, it's amazing. There was no, like when I first started 20 years ago, there was no talk about Medicare was paying for no prevention. It was all like, we'll pay for 911, we'll pay for the ER, we'll pay for the hospitalization, the rehab that goes with it, and that's it. Like hard stop. And I really thought that was the way it was like forever. I didn't know you could change it. But being here this year was amazing. Like they're focusing on long-term support and services. They're focusing on preventive medicine. The U.S. Preventive Service Task Force actually came up with these, rules around it. So there is this shift. I mean, like I said, everything is slow, right? If nothing's going to happen fast, but they're actually paying, they're paying for caregiver support, which was like unheard of. So it's a matter of who's elected to the House and the Senate and what their priorities are, because they can get things changed. But it's also this advocacy because all these senators, they have their own families, they have their own personal experiences. I think people are starting to realize, actually we do need to do prevention. So it's just going to be over time, but it's already starting to change. So yeah, that's a lot. We can talk more about all the details, but yes, thank you. Thank you for that great question. Yeah.
Quick question. There's Medicare cuts coming to physician compensation this year. The way I understand it, really they're just adjusting money from this bucket to this bucket. So basically, each year, I'm guessing that hospital systems get paid perhaps slightly more, from the same some budget, and that has to come from somewhere, and that seems to be coming from, physician compensation budget. So my first question is, am I correct or wrong? And number two is, so what's the most efficient way to lobby to stop some of these things, which I think is directly causing a lot of physician shortages in most of our fields, such as primary care, pediatrics, and things like that.
Yes, this is a huge issue, this physician compensation. When I went and met with all the offices, like, um, um, all the Kentucky delegation, that's what they were talking about. Mitch McConnell's office, that's the first thing they said was this physician. I was like, I wasn't actually going to talk about that. I was going to talk about the nursing home and hospice, but they were all over this. So I think this advocacy that physicians have had for so long, and just to keep it up, because it is front of mind. They know that people are leaving medicine because of it. And some people are going into certain specialties because of it. And so like in Senator Warren's office, we had a lot of people come meet, and some of these, and it depends on where you live, like Massachusetts, some parts it's very high cost of living. And these doctors are like, I can't even buy a house. These are doctors, like I can't buy a house, And so it's like, why should I even stay in medicine? I can make more money doing other things. And so the House and the Senate and Congress really has heard that message. So I didn't get a heads up like what the next solution. They keep fixing it like piecemeal. A lot of it is CMS changing what they're paying for. Like right now, CMS is starting to put a lot more money into paying for like primary care prevention stuff. Like, they'll if you have a long-term relationship with the patient, like these new codes, like the G2211 code, like you get paid $15 if you have a long-term relationship. I mean, they're trying to do what they can to like help people stay in primary care, because some specialties are actually doing okay. I mean, they're getting cut, but they're still doing some specialties. This cut is like, and a lot of people can't have their own private practice anymore, right? Because that's why there's hardly any private practices out there. It's all these health systems because they really can't afford to do it. So it's a huge issue that came up like every time people spoke. And so that's what's keeping it front of mind for the House and Senate because of the advocacy. So the advocacy works, and you're right. They're going to fix it. It's just moving money around. And I didn't answer your payer exactly about single payer, if that's a big thing. I don't think it's the way you say things too, right? Because like these states that did start adopting this Affordable Care Act Medicaid, they couldn't call it Obamacare because they don't want to be associated with Obama. They couldn't really even call it the Affordable Care Act. They called it closing the coverage gap. And it got passed in North Carolina because they called it closing the coverage gap. So I don't know if single payer is attractive or not, or just like maybe we should, because a lot of people are very excited about changing prior authorization, because prior authorization is a nightmare and people realize people are getting denied care. Well, prior authorization is because we don't have a single payer. So I don't know, it's going to be the way they say it, but there was not a lot of talk about single payer, really. I don't know what they're going to call it, but so we'll see. Yes.
I don't want to go over, but we
Yeah.
have one question in the chat area. Let's know, is there any appetite at CMS for reducing waste in healthcare?
Yeah, there's a lot of and the Office of Inspector General, that's what they do. And like this waste, what do you call waste? A lot of this private equity, like giving money to the CEOs or giving money to like, not I shouldn't say CEOs, but the investors and like it's mostly the investors, like the private equity, these REITs, and that's waste, right? Because it's not really taking care of patients, but then you need some of it because the private equity does give you a new coat of paint or new building. So you can still do private equity and REITs that take care of the patients. It's not all bad. It's just some of them are bad, right? So there's a lot of audits. There's a lot of audits, and they're trying to what's waste, like moving it forward, right? So you prevent stuff, because you could consider waste as like fixing it after it's broken. If you prevent it to begin with, that would be like, not wasteful. So yes, there is some, but there's agents, and you think, oh, government's so huge, but that's some agency, that's all they're doing is looking at fraud, waste, and abuse. So that's their job, and they're doing a good job of it. Yeah.
That's all from the chat.
Cool. Well, thank you all so much. It was really great. It was a great conversation. So thank you.
Yes. Oh.
Oh, shit. This is just for people. I thought this was just if you're like out of town or something.
We changed the policy. Cash was so important. Thank you so much. You're one of the first internal speakers to actually benefit from the new policies. You gotta change some things sometimes.
Okay. Oh, I love it. Thank you so much. Oh, that's so great. Christian Furman. Oh, this is awesome. Thank you, Clay.
You have a minute?
Yeah.
We need to do